You can see this is what would be left, but it would be throughout the entire distribution of the infusion set. It wouldn't just be, as was found at the crime scene, in the very distal part of the delivery system.
So from the answer, the court will strike the word crime.
Oh, excuse me.
That's deleted at the scene. Thank you.
I apologize.
So you'd expect there to be residual in the IV bag. You'd also expect to be a residual in the chamber and in the IV line.
Yes, sir.
Now, the evidence that was seized at this scene, there was no IV bag with any propofol, correct?
Correct.
No IV line with any propofol in it, correct?
I think the evidence...
Just a moment. Overruled. You may answer.
Sorry. I understood that there was propofol found in the distal part of the line.
Okay, but not in the
But
upper part.
not above the side port.
So that would be consistent with the propofol being delivered by use of a syringe.
Correct.
So, in forming your opinion on infusion, when you see that there's no propofol in any delivery device other than the distal end of the IV line, there's no deployment of the strap used to hang the propofol bottle, does that cause you to think that there's no evidence of an infusion?
Exactly.
Now, I want you to take a look at Dr. Schaefer's.
But I would add that's not the only evidence.
What other evidence?
I think you're going to show some. I just want to state that there are other reasons that I question as well.
Okay, well, I'd like you to refer to the diagram that Dr. Schaefer did showing, I believe that's an infusion between the hours of, I think that's 9 a.m. to 12. That'd be noon. Now, that diagram, you see where at 12 o'clock well, first of all, on the upside, you got the blood level and the brain level going up very close to each other.
Yeah. Normally, the blood level goes up significantly faster, and there is a slight difference. This is a compressed scale, being 3 hours. So, but there's usually a lag between blood going up and the brain concentration going up.
Well, look at where it's going down, though, at 12 o'clock.
Yes.
Now, we know that the 100 milliliter bottle,
Ask what exhibit number this is.
this is S.
Quadruple S.
The 100 milliliter propofol bottle that you have is empty. Correct?
Yes. It had a spike mark in it, and it's empty.
To do this scenario of infusion, does this assume any kind of coincidence?
I'm not sure what you mean by coincidence, but I guess it assumes that the patient died at exactly the end of the infusion. Right? I mean,
At exactly the same time that the bottle became empty, the patient dies?
that's what it says to me, yes. And I
Well,
think that's what Dr. Schaefer suggests.
Based upon that diagram where you've got the patient approaching levels at, I guess it's about 10 o'clock where it says responsive only to painful stimulus. Is there anything that, if it didn't cause the patient to die at 10, that would cause him to die at 12?
Nothing that I can imagine.
I mean, this scenario never gets to a high level like 6 or 4, does it?
No, and in fact, I would just comment that having done thousands of cases of using infusions like this for sedation during local anesthesia and during procedures, patients who are breathing spontaneously, there would be no reason for them to stop breathing if you're giving this continuously. In fact, the infusion rate, I actually calculated what the average infusion rate would be if you gave the entire 1,000 milligrams over 3 hours. And it's precisely in the concentration range that's recommended in the package insert for propofol. It's just slightly higher. It's 89 micrograms per kilogram per minute. And the package insert suggests a range of 25 to 75. But as a practitioner, I will tell you, we commonly give 90 mics per kilogram per minute for conscious sedation in the operating room.
Now, the level between 10 o'clock and 12 o'clock is very little change, isn't there?
Right.
Is there any change there that would cause a change in condition of the patient?
None that I can imagine. I mean, a patient typically in the operating room with that kind of infusion and the modeled blood concentrations would be sleepy, but arousable in most cases, but breathing spontaneously, and there would be no reason that they would suddenly, I guess he could hypothesize that he's developed laryngospasm suddenly just at the end of the infusion, which would require an incredible coincidence of circumstances.
I mean, if he died before the end of the infusion, say on that chart at, say, 10:30, 11, would the infusion continue to go?
I don't believe so. I mean, the circulation stops. The drug would build up, I guess, in the vein till the pressure, I've never done any experiments in dead people, but I can't imagine it would run very long. And the other thing is inconsistent is if he was running this concentration through a distal vein, that is a small vein in the back of the knee, it's going to drain into the leg and into the femoral vein. And the femoral vein is where they measure the concentration. So I would expect that if in fact he was getting this high concentration, undiluted propofol, that the concentration in the femoral vein would have been higher. But again, that depends on which femoral vein the coroner used for the sample, and I couldn't find that information.
But if the blood is not circulating and you've got an infusion going, the blood's not circulating, does that create a reverse pressure that stops the infusion?
I would imagine it would, yes.
Now, I've got another diagram I'd like to show you. I'm going to mark this quadruple T.
No, uniform.
Unicorn.
Uniform.
Uniform.
U.
Okay. Now, once again, this is another diagram that you have prepared.
No, it was prepared for me at my request by Dr. Gabriella Mellon Ornelas.
What does this depict?
This two-part diagram on the upper panel shows the propofol concentration in micrograms per milliliter when you infuse 1,000 milligrams, that is the entire bottle here, over a period of 180 minutes and achieve a similar blood level profile to that reported in Dr. Schaefer's simulation, and demonstrating a very similar decline at the end of the infusion. But in addition, and more importantly, what it illustrates in the lower panel is the elimination of unchanged propofol. Now, you all know that propofol is extensively metabolized, but there is a percentage of propofol that is eliminated in the urine in an unchanged form. And at autopsy, they determined that the level of unchanged propofol in the urine was extremely low. In fact, on this scale, which is a somewhat expanded scale so that we could show what would actually be expected based on the amount of propofol that was given with this model and the amount of metabolism and elimination that would result. This shows the unchanged urinary concentration of propofol.
That's the dotted line at the bottom.
The dotted line at the bottom is the level of unchanged propofol that was reported at autopsy by the coroner.
And the red line in the middle, what is that?
That would be, again, the average concentration of unchanged propofol that was eliminated, not the amount shown on this slide, which would approach actually 2 milligrams of propofol.
Now, there's on that red solid line, there's a couple dotted lines on each side of it. Could you explain what those are?
Well, these are just the uncertainty limits. These are just, Dr. Schaefer talked about 2 standard deviations above and below. It just accounts for the variability that I've been discussing with you in the last couple of days. So it could vary anywhere within this range. We're just giving you kind of an idea. But in no way does it come close to the level reported by the coroner at autopsy. Even in the extreme situation when you would have maybe poor renal perfusion or some other reason for having low elimination of free propofol, the level would still be far in excess of the level reported at autopsy if Mr. Jackson had received 1,000 milligrams of propofol during the 3 hours prior to his death.
So you can kind of confirm or negate the 3-hour infusion of the 1,000 milligrams by looking at the metabolism that occurs in the urine. Is that correct?
Not the metabolite. This is unchanged propofol, free propofol, not the metabolite.
So
A
that's
small percentage of propofol is eliminated in the urine as unchanged propofol. The majority is the propofol metabolite.
so.
And this just looks at the free or unchanged propofol.
So in the event that the infusion were done as it's described by Dr. Schaefer, you would expect a urine concentration of unchanged propofol at the level of 2, plus or minus the deviations that are depicted by the dotted line.
Correct. Plus or minus 1, so it would be a range of 1 to 3.
So it's totally inconsistent with the level of urine in the urine that was obtained by way of analysis at autopsy.
Correct.
I've got another diagram I'd like to label as quadruple V.
Victor, yes.
Dr. White, we got quadruple V up there. Would you explain what that diagram shows?
Well, this diagram basically summarizes a scenario that we propose took place on the morning of the 25th. On the upper panel is the propofol concentration in micrograms per milliliter. Here at around 1040 or 1045, a 25 milligram bolus injection of propofol and 25 milligrams of lidocaine was infused slowly through that distal side port as I demonstrated earlier, and we would result using the Schaefer model in the following curve, which we actually used Dr. Schaefer's simulation. And then if just sometime prior to noon, Mr. Jackson had self-administered an additional 25 milligrams propofol with 25 milligrams of lidocaine, it would very rapidly, which is the way most individuals inject propofol, unless you're doing it intentionally very slowly. It's hard to actually do it that slowly. And it would result in this peak concentration. And more importantly, If we look at the unchanged propofol, and I think this is very, very significant in this case,